This conference will now be recorded.
So before we move into this next section, just wanted to check and see if anybody had any questions that arose from the last section while you were on break. Had any inspiration or comments? Okay. All right. So the next section, we're going to shift gears here a little bit, and then we're going to talk a little bit about the Medicare program. And not sure, where each of you all are at in terms of your background, your experience. I don't know where you are in terms of whether you're in your AIT or whether you have started it yet or not. So I'm going to presume that everyone's kind of all over the board in terms of what they do or do not know on Medicare. And this is, as I said earlier, this is going to be a presentation that's geared to you in your role as an administrator. And it's going to be program basics. And so some of this, if you've got some background and knowledge, may seem repetitive or redundant, and for that I apologize. But there are others that may not have that same level of knowledge. So we've kind of built this as kind of a step one guide, and we're going to talk a little bit about the the program itself. We're going to talk about some of the various agencies or entities that typically interact with skilled nursing facilities. Some of the program mechanics in terms of components, consolidated billing, how a provider gets paid, and then some of the resources that you have available within your program, some implementation strategies, some recent changes, and of course, trying to maybe look into the crystal ball a little bit and see what may be ahead. And so with that, with Medicare, you can take one of two approaches. One is you can get out there and swim with the sharks and, be an active participant and, uh, reap the benefits. Or you can put your head in the sand and treat Medicare as, just another payment mechanism. For the vast majority of providers, Medicare is essentially the last bastion where you can actually achieve some level of margin. Unless you've got a high private pay census and your rates are such that, because private pay will go straight to the bottom line. Most of the private pay has been absorbed over the years into assisted living, and that's just the way it's been. And so Medicare is really that last and best opportunity for you to uh, you know improve the bottom line for your organization. Secondly, and just as importantly, it's a program that is uh, almost expected by your customers, both in terms of referral sources as well as your the families and elders out there needing services. And it's still highly misunderstood. We should strive in our role as the administrator and leaders of our organizations. We should be striving to be known in our communities as the experts on the skilled nursing benefit. Okay, not necessarily Medicare in general, but we should be the ones who should be promoting ourselves as the experts on the skilled nursing benefit and not deferring to discharge planners or physicians who, my experience has been, don't have a clear understanding of what the skilled nursing benefit does and does not cover. So a little history. Medicare, of course, was enacted in 1966. It was signed into law by LBJ back in 1965. Who is, I'm not sure what's going on there. Coverage was expanded in 1972 to include I don't, is somebody, I really don't know what's going on here. I'm not touching it. Coverage expanded in 1972 to include elderly, disabled, and end-stage renal disease patients. This next bullet point is actually a misnomer. CMS was actually not the name known as the agency, the name of the agency in 1977. It was actually the Healthcare Financing Administration. And so CMS actually did not become the name for this agency until the 1990s. The drug benefit, Part D, was added as part of the Medicare Prescription Drug Improvement and Modernization Act of '03. And then as of 2017, we had a little over 58 million beneficiaries enrolled. 750,000 of those were in Oklahoma. And that includes both those beneficiaries enrolled in traditional Medicare as well as the Advantage program, which we'll talk a little bit more about. As far as program administration goes, of course, Medicare is underneath the contractor, which is the Centers for Medicare and Medicaid Services. It's administered. What is going on? It's administered through the Medicare administrative contractors. And our particular MAC, if you will, here in Oklahoma is Novitas Solutions. But all of this rolls up underneath the Department of Health and Human Services, which is a cabinet post. And so CMS is one of numerous agencies that report to the Secretary of Health and Human Services, which is Alex Azar. We also have carriers, which is Part B, and that's going to be primarily your durable medical equipment, things that are excluded from consolidated billing, that sort of thing. We also have QIOs. Of course, QIOs over the years have regionalized. KeyPro, for purposes of Medicare program in terms of the discharge process, dealing with demand billing, things of that nature, is KeyPro. And of course, we know that Telegen is involved in the quality improvement side in terms of technical assistance and dealing with like infection control, consultation, that sort of thing. And then there's also medical review, which is performed by both Medicare administrative contractors as well as recovery auditors. And then there is error rate testing that's done by agencies called CERTs. And you may get an occasional contact from a CERT, but generally speaking, CERTs are not going to be directly in contact with your organization. They exist more to advise the MACs and the RACs and then the CMSs. Okay, so some mechanics, as I made mention, Part A is inpatient services. It's also known as hospital insurance. And there's Part B, which is Part A, of course, is something that people qualify for simply because of their age or disability status and their number of quarters that they paid into the Social Security program. Okay. Part B is medical insurance and is something that is optional. Not everybody automatically receives Part B. They actually pay a premium for it. And so you may have people come into your buildings that have Part B and some that may not. Part C, of course, is Medicare Advantage. And they have consciously made a choice to move to an Advantage plan instead of traditional Part A. And it may be Humana, it may be, other insurance companies that are administering the program. But Medicare Advantage is managed care, okay? And so they may have some nuances associated with their policy. And so it's important to make sure you check the policy as they're coming into your organization closely. They may not always have the same qualification requirements as traditional Part A might have. And a good example of that, of course, is the 3-day hospital stay, which traditional coverage requirements under traditional Medicare will cover. So make sure that you've got a system in place to check that policy closely. So some qualifiers for admission. First of all is you should be checking to make sure that beneficiary has a Medicare card or evidence that they have coverage. Many times I've seen the elder will not present with the card, and then the family has to go and dig it out of some shoebox in the back of a closet someplace, or they have to go down to the Social Security office and get a verification or duplicate card, and so that they can so you can verify that they have coverage, and that you've got a 3 midnight hospital inpatient stay. And right now, under the public health emergency, there are some waivers that have been issued by CMS, and the 3 midnight stay does fall under one of those waivers. And so, absent the public health emergency, though, right now, uh, you know, it, absent that emergency, then there still exists the 3 midnight hospital inpatient stay. Now, that means 3 midnights and in a inpatient stay in a hospital. Okay, so if they were in the ER under observation or less than 3 midnights, then they would not qualify. Okay, so they have to have an admission to an acute care bed to be able to start the process for qualification for the skilled nursing benefit. They also, and many times, our patients don't necessarily come to us directly from the hospital. Most do, but not all of them. And as long as they've been discharged from the hospital after having that 3 midnight inpatient stay within the last 30 days. Okay, so you might see somebody come from home, and so absent asking if they've been in the hospital recently, you may not know whether or not they've had a qualifying stay. And so you may miss out on an opportunity for an individual to take advantage of their Medicare benefit in a skilled stay if you don't have a system in place to inquire about that. And then, of course, also that they have days remaining in their benefit period. And again, right now under the waiver, the 60-day break is not in play. But absent the public health emergency, there is a benefit period can only be broken by 60 consecutive days of not receiving a skilled level of care. Okay, so once they've exhausted their benefit period of 100 days, we'll talk more about that here in a minute, then that benefit period does not renew unless they have a 60-day break. Okay, Now, there's actually a flaw in the system that there's one type of scenario that I've run across where you have an individual that may never get a new benefit period in, again, outside of the public health emergency. And what that is if somebody is receiving a skilled level of care because they are being tube fed. So a G tube will potentially, if they are highly dependent on that G tube for their nutrition and hydration, then they obviously will never have a renewal of their benefit period. Under the waiver, that is, of course, exempted. So it's, right now, that's not necessarily in play. But once we go back to, or once the public health emergency goes back or is ended, then many of these provisions will go back into place. One is the thought is that hopefully that 3 midnight stay will be eliminated even after the public health emergency is done, but that is yet to be seen, of course. So in addition to having the card, the 3 midnight stay, been in the hospital in the last 30 days, and having days in their benefit period, we also need to make sure that they've got a clinical category that will actually map to an ICD-10 code that is coverable under the patient-directed payment model, okay, under PDPM. Because under PDPM, nursing is managing the system. And so your MDS coordinator and your team has got to assure that when that individual is coming in, that they map appropriately to a code that will allow you to be paid based on the services that you're delivering. So under Part A, in the benefit period, if they've had that qualifying three midnight stay, then they will, within that 30-day period prior to the SNF admission, and that they meet certain clinical or rehabilitation coverage criteria, then they have the ability to use their 100 days or benefit period or spell of illness under the Part A program. Okay, so all of those things have to be in play in a traditional Part A stay. Now, Medicare covers all charges for the first 20 days. And within that 100 days, days 21 to 100 are requiring a copay of $176 per day this year. And that changes from year to year based on a lot of different criteria that CMS sets. So we'll see what happens for 21. Obviously, we're in the last quarter of 20, so we should be seeing something coming out soon about what the copay will be for 2021. That copay many times is often covered by third-party insurance. Medicaid programs, varying from state to state, may or may not cover or private pay, basically. Okay, I do not know why this has got a mind of its own. Okay, so the benefit period, what's covered underneath that rate? And so a semi-private room, or if you happen to be a community that has all private rooms, that would be applicable. Of course, all meals, all routine nursing services. Of course, rehab, and we'll talk more about this in a little bit, but rehab is covered under your rate, as are drugs, medical supplies, lab and x-ray services, some ambulance services, and even some hospital outpatient services are expected to be essentially covered under what we call the bundle of your Part A rate. Okay, so this has got a lot of different components that are, or expenses that fall underneath the reimbursement or the payment that you're receiving under the Part A program, under PDPM. Okay, so your benefit period begins when they're admitted to the hospital and ends 60 days after all skilled services that they've been receiving have ceased. Okay, and that's dependent, of course, on location and the type of services, but generally speaking, after 60 days, that's that 60-day break before the benefit period is renewed. So what is a skilled service? A skilled service is those services that are furnished according to a physician order. So you got to have the doctor's order. If we all know if you didn't document it, you didn't do it, and you can't do anything without an order. And so a skilled service is something that is required to be delivered by a qualified technical or professional health person. So an RN, LPN, you know, therapist, all of these are skilled health personnel. And not to say that nursing assistants and the like don't provide part of those services, but they have to be seen or overseen by these professional health personnel in order for it to be a skilled service. And again, it must be provided directly by or under the general supervision of those personnel, so that because otherwise it's just routine care. It doesn't rise to the level of skilled services. It's got to require a skilled person to oversee it for it to be a skilled service. So under Part B, now the part therapy is the only service that is required to be provided and billed for by you as the skilled nursing center. That is all of the other Part B services. You certainly have some options on some of them, but therapy is the only one that you are required to bill for. And so there are some thresholds that are kind of loosely in place. We used to call them the therapy caps. But for Part B, there are, for just your building, it's actually in skilled nursing, the thresholds are 2,080 for PT and speech combined, and then OT has an additional 2,080. Now that's whether or not they do it all just in your building or whether they've been in one building and then come to you. It's not 2,080 per site, it's 2,080 for during the entire skilled benefit period. Now, as I said, they're a loose threshold because you can exceed them if they qualify and you add the KX modifier for medical necessity, meaning that they required additional services that went beyond those thresholds. Now, in addition to that, okay, so Tracy's asking, is this based on a minimum amount of service? Well, that depends. Like, no, I mean it's based on how the units that are being provided. Okay, so 2,000, and so that doesn't go very far, does it? Yeah, so generally speaking, most providers should be able to verify and confirm medical necessity, and as long as that KX modifier is being added to the UB04, then that lets CMS or the MAC know that you're verifying medical necessity and this patient should be being able to receive. Now that doesn't mean that the MAC won't come back and basically question it. And so that's what we call an additional development request. And so your business office might receive an ADR where you would have to basically defend that medical necessity to the MAC. Now, in addition to the threshold just for skilled nursing, there's also a $3,000 threshold for medical review that incorporates any therapy services received outpatient anywhere. Okay, so whether it's in the hospital, um, someplace else, there's also the threshold, and the same KX modifier comes into play. It involves complex medical review. And so, as I said, hospital outpatient, it also includes critical access hospitals. Okay, so if you're in a rural community where your hospital is categorized as critical access, therapy received while there may also follow under that threshold. Now, CMS is basically contracted with supplemental medical review contractors, or SMRCs, to kind of monitor the utilization underneath this threshold. Okay, so again, therapy for Part B, the $3,000 threshold applies just beyond the skilled nursing setting. It encompasses any therapy services received, after the acute care stay. Okay, so Tracy, did that answer your question?
Yes, it did. Thank you.
Okay, good. All right, so before we move into consolidated billing, any questions from you all regarding kind of the basic mechanics of Medicare to this point? Again, I'm presuming that we're all over the board in terms of our knowledge and experience, and it may be that this was a refresher so far for a lot of you, but maybe not. So,
Well, for us that are new to this, it's kind of overwhelming. How much is this on, like, on the exam? I mean, I know this will come with time while working as a minister, but is this really going? Is this going to be a lot of this on the NAB test? I mean, because I'm kind of confused about it, to be honest with you.
there will be some content that is covered on the NAB, but it's probably not going to go to the level of detail. I mean, they may ask you questions about difference between Medicare and Medicaid. They may ask you about qualifiers, things of that nature. They're probably not going to delve overly deeply, but
Oh,
my objective here is not just to prepare you for NAB, but to help better prepare you as you aspire to be an administrator. And so
no, I
it's
appreciate that. And I'm just, like I said, every day, every week, it gets more clear. But and you've answered some questions that I've had in the past, but it's just the medical billing part is a little overwhelming for me. So I appreciate you going through this.
sure. Yeah, and as Z says, the NAB are entry level questions. So this is, the level of questions is basically to test that entry to practice. And so they're not going to expect that you're going to have all the answers and all the detail that goes into it. What I'm providing you is a little bit more advanced than just the entry level.
Thank you.
Mhm. Okay, so consolidated billing, fun. So consolidated billing is basically there are things that, as we talked about earlier, that are considered to be contained underneath your rate, the bundle, if you will. Okay, but there are certain services that are carved out or excluded from consolidated billing. Okay, now consolidated billing, if I get, questions that I get from clients, I would say, probably 75% of the questions that I get from clients pertain to consolidated billing. It's because it's just you cannot completely understand. You don't have the answers to everything because it's not just black and white on many things. But for our purposes here, what I want you to understand is that your PDPM or your Medicare rate that you're paid covers most services, but not all. And so what we're going to talk about here is some of the services that are carved out, and they are broken into categories that are excluded services. Okay, the first four are services that are excluded or carved out, and the fifth category pertains to the therapy services, or the Part B that I referenced a little bit earlier. And so the category one, these carved out services are provided by an outside supplier or you, that you can bill separately for that particular service. So category one is those services that are beyond your scope as a skilled nursing facility. And we'll give some examples here in just a moment. Category two is services that pertain to some specific beneficiaries. Category three is services that can only be provided by certified providers. And then category four is services that are more preventative and screening in nature. And so category one are those that are outside of your scope. So just check, making sure nobody's doing CT scans within their organization, any cardiac cath, and anybody doing MRIs? Okay, crickets. All right, that's good. Because you cannot bill for that if you provide it in a skilled nursing setting. Okay, these are services that have to be done by another provider. In fact, these particular services must be provided on an outpatient basis at a hospital and not by a SNF. Okay, and so HCPC, or healthcare procedure codes, in the fee schedule, the patient should always go to the hospital to receive these services, or you could end up eating them as part of your rate. So it becomes an additional expense that is unnecessary. So the important thing to remember here is, for instance, let's just utilize MRIs. Okay. So we know that there are some hospitals will bring in, or there may be an MRI, in these trailers that park in, these parking lots or whatever. And it's very clear that these services have to be provided at a hospital within the confines of those four walls. Okay, so make sure that if a patient of yours that is in your building and being covered under Medicare Part A, if they require any of these type of services, that they be done via a hospital, so that the hospital can bill for them instead of you having to be billed by the hospital for that expense, or that provider, not the hospital, for the expense. Okay, so these are services that not only you can't do, but have to be very clearly provided and verified that it's being done within the confines of the hospital. Category two is those services that are for specific beneficiaries. Okay, and so what we're talking about here relates to dialysis, both in terms of dialysis supplies and equipment. I imagine that many of your buildings probably do have patients that require dialysis, and I'm not talking about the dialysis that can be done at the bedside. I'm talking about the dialysis where they actually have to physically go out to a dialysis center, and they're gone all day, and then they come back, and they come back to to your building to receive, other care that goes along with that. And in this particular category, the SNF does not pay for any of these services, and that includes ambulance transportation back and forth. Okay, you may be liable for ambulance services for other types of care, but not in this particular category. So category 3 is certified providers. Okay, and so these are services that can be provided by any Medicare provider that's licensed and certified to provide them, except you in a capacity as a skilled nursing facility. And so this is things such as chemotherapy and chemo administration, radioisotopes, certain customized prosthetics. These are things that are, for instance, in the fee schedule, these are called chemo, I think is the J codes under the healthcare procedure codes or the HCPCS codes. And so these are all things that, the provider of these services can bill for them, but you can't. Okay. Again, these are carved out of your Part A rate. And category 4, and this is something that are carved out, but many times providers don't realize or don't take advantage of the opportunity. These can be billed by you, but they're carved out of the rate. Okay, and so this is many things such as vaccines, screenings, mammograms. These are all things that are carved out of your Part A rate. Vaccines, for example, both pneumococcal as well as influenza, and hopefully soon a COVID-19 vaccine, would be roster billed. And by that, what I mean is you basically you have a whole list of patients and their information, and you're billing all of them for the same service all at once. Okay, but you're billing that outside of your normal billing process for Part A. This would be done under Part B. Now, the category 5, as I said, is therapy services are covered as Part B benefits, but not included in the SNF PPS, but still must be billed by you for beneficiaries in a Part A stay if they have Part B eligibility. Okay, so you're billing for therapy even if it's Part B or Part A. And so rehab therapy services are considered to be included for the SNF PPS and consolidated billing for any beneficiaries who are with you in a Part A stay. And then, of course, extend that beyond and then are billable under Part B after their benefit period's over or they no longer qualify for Part A in terms of their the number of days a week that they're receiving services. The other thing to remember here is that a skilled service must be provided at least 5 days a week, okay, for therapy. And for nursing or clinical services, those have to be, of course, provided 7 days a week. Okay, so again, very high level on consolidated billing. You may get a very basic question on that on the NAB. Not positive. Again, it's pretty complex, and so I'm not sure the NAB will actually even speak to that. The Medicare inpatient notice is something that I want to spend a couple of minutes on, because you as a provider, if you have a patient that's with you in a Part A stay and they require a service, for instance, if they have to go to a doctor's office for a physician visit, or if they have to go to the ER for something, then you are required to let them know that that patient is with you and a patient of yours in a Part A stay. And so you're required to send that ancillary provider an inpatient notice. And this is a one-page notice to providers outside of your services that that patient is with you in a Part A stay, and requests them to contact you prior to providing services, because if you are, you're the gatekeeper here, and so you're likely going to be case managing that, because you're going to be likely receiving the bill from this outside provider for that patient for those services underneath the bundle. And it provides guidance in terms of charges for those services. And so many SNFs, and you can't necessarily do this with every single provider, but some of your primary, maybe your primary attending physicians, your medical director, main referral hospital, that sort of thing, as well as your other providers such as therapy, medical supply, pharmacy, that sort of thing, having under arrangement agreements. What you want to do is have an understanding in writing between you and that outside supplier that clarifies the fee schedule. What is it that, what are you going to pay, and the terms for payment underneath them, meaning basically, okay, we agree that for a patient of mine that's in a Part A stay that comes to you, I will pay 90% of fee schedule, or 75% of fee schedule. And payment terms means that you will bill me promptly so that I can then turn around and bill Medicare, because you're going to be receiving the bill and incurring that expense underneath the rate that you are billing Medicare for. And CMS has provided some sample under arrangement agreements at this particular web link, and so that's on your slide. And so this applies to various types. It may be a hospital, like I said. They may need to go out for, for instance, a debridement, or maybe they need a swallow study, or any number of various things. And so you want to have a very clear understanding of what they're going to bill you for that service, and when they will be billing you, because you want your invoices to come quickly instead of them waiting to send an invoice to you, 6 months down the road. Okay, so a provider gets paid, of course, driven by the minimum data set. And so the minimum data set has a lot of different implications in terms of, not just payment, but survey. It drives quality measures, and vicariously those quality measures and the information contained from the MDS drives decision making, because those quality measures are up on Nursing Home Compare, and many referral sources are consulting the Compare website to look and see how your building is doing in specific areas as it relates to care delivery, as well as survey performance, as well as staffing. The MDS drives the quality measure piece of that, of course. And so it also drives Medicare reimbursement. And in a growing number of states that are under case mix, Medicaid reimbursement is also driven by the MDS. And so bottom line is the MDS has to be accurate. And so I'm presuming that all of your buildings have somebody dedicated to that role, at least one person, I would say it would be wise if you had somebody in a backup role so that your MDS coordinator can take a vacation from time to time. Or if for some reason they fall ill, or if they got COVID and had to quarantine, you see where I'm going with that. Having backup is critical for the MDS role. And so having an understanding of that process and making sure that that individual has the time and resources to be able to do their job to the best of their ability. In fact, there are some buildings, and I don't know if any of yours have gone this direction, but to eliminate the temptation for DONs or ADONs to pull an MDS coordinator in a staffing crunch, many buildings that I'm aware of are actually having the MDS coordinator report directly to the administrator and kind of elevate them into a management position. So that's something to consider if you so choose. So what is this thing called PDPM? As I said, it's patient-driven payment model, and we are literally just past the 1-year anniversary of its implementation. Okay, and the specifications were included in the final rule in July of 18, went into effect October of last year, and of course, we had not gone very many months before the pandemic hit. And so providers, obviously their attentions were basically diverted to the issues associated with the pandemic and COVID-19. And so referrals have been down. So PDPM has kind of taken a quasi back seat to things. And only now are we seeing providers kind of starting to refocus on having a better understanding of the PDPM model. And so transforming our organizations to move from a RUGS 4 environment, we have to essentially, as I mentioned earlier in the previous session, it's a cultural shift. I mean, we can have all the strategy in the world, but if we don't have our culture in the right place, as Peter Drucker says, you can see on this slide, culture eats strategy for breakfast. And so we can have the best strategy, but if our culture isn't there to support that strategy, it'll fall by the wayside. And when it comes to PDPM, the payment mechanism is what's going to help drive our culture from the financial perspective. Okay, so as we've transformed from RUGS 4 to PDPM, we've got to shift our culture accordingly. So a little bit of a spoiler alert, ICD-10 coding historically has been a compliance piece, meaning that as we've completed the MDS, we have our MDS coordinator has been required to enter ICD-10 codes. That's really been just basically a compliance issue. Well, with PDPM, that has become somewhat of a payment driver. Okay, we thought it was actually going to be more of a driver than it really has been, but still yet, the ICD-10 code has to map to a specific group of codes that will allow you to be properly paid. In addition, rehab, which was a highly payment driver. In fact, most of our Medicare programs up to this point were highly dependent on rehab to drive our payment. I mean, it's most of the utilization that I've seen leading up to PDPM was driven by rehab, 90% plus in most cases. And so under PDPM, however, it shifts from being a payment driver to simply just another ancillary expense. Okay, Not that it's not necessary, not that it's still not a critical element of our skilled program, but we have to understand that even despite its importance, it is simply another ancillary expense. It's not directly going to influence our payment. And then, of course, ADL to functional scoring, where we are capturing patient conditions. That hasn't changed. ADL scoring and functional scoring are all still a very vital part of our overall skilled management program. And quite honestly, over the years that I've seen with rugs, excuse me, providers have not done a good job at ADL scoring. And so, unfortunately, the song remains the same here, because if we weren't doing a good job with ADL scoring before, we're perpetuating these deficient practices related to ADL scoring as we moved into PDPM. And so if we don't take a QI approach and improve our ADL scoring, we're still not going to be optimizing our ability to get paid what we should. And so PDPM really was a good move from the federal government to truly enhance and basically walk the talk of patient-centered care, because PDPM, patient-driven payment model, truly really is about that patient and what their needs are. Okay, so PDPM model rate components. Okay, so we're going to talk about, there's a total of 6 components that go into the payment model. And for purposes of our discussion today, we're going to talk about the first 5. Non-case mix really hasn't changed in terms of whether it was in the RUG system or PDPM. And so that is kind of it's a part of your rate, but it's not a part of the rate that has changed from one system to another. The other 5, however, have. And so what we're going to talk about are nursing, non-therapy ancillaries, and of course, PT, OT, and speech language pathology, which for the first time are all separated out from each other in terms of the rate structure. And so on this slide, what we're seeing is you've got per diem base rates. Okay, so we start out with a base rate, and these are urban rates. You may or may not be in an urban area, you may be in a rural area. Okay, so CMS comes out with national per diem base rates, urban and rural, and then there is a case mix index applied to each one of those 5 categories that moves. So the base rate plus the case mix index will give you a base rate, okay, a total base rate. And as you can see, the range on an urban perspective can be anywhere from, for instance, like nursing can be anywhere from as low as $68 a day to as high as almost $418. Okay, so you've got a wide range on many of these categories based on the case mix index that goes into it. So the way that we arrive at a rate in terms of your payment is each one of these components is separate. And so your PT rate, your base rate times your case mix index, and then 3 of these components, PT, OT, and non-therapy ancillary, also have a third adjustment in the form of an adjustment factor. And we'll delve into this here in just a minute. So non-case mix, again, We're not discussing that, but that's the sixth component. So PT, OT, speech, nursing, and non-therapy ancillaries all have a base rate. They all have a case mix index that is multiplied times that base rate. And then beyond that, PT, OT, and non-therapy ancillaries also apply an adjustment factor to get you to each one of those components is added together for your total payment for that particular patient for that Part A stay. Okay, so some comparisons here. So under RUG 4 versus PDPM. So you can see, in a RUG 4 environment, nursing and non-therapy ancillaries were not separated out. It was just simply a routine component. Okay. Similarly, PTOT and speech, you just had a rehab component. And then, of course, the non-case mix. And so under PDPM, you've got these components broken out. Now, notice that the routine component, which is nursing along with non-therapy ancillary, is very comparable to what it would have been under the RUG 4. Okay? The difference, though, is when you move down to the rehab component. Okay, so you can see that under PDPM, there is less of an emphasis on the rehab component. Okay, and so remember what I said a couple of minutes ago in terms of therapy is not a payment driver. Well, as you can see there, and for years we've had this assertion by the OIG and CMS and MedPAC and all these organizations that says, oh, you're overutilizing therapy, and so they've had this, this strategy to try and reduce the level of therapy utilization within the skilled nursing setting. And so moving over to the case mix index, so you can see a case mix range that's applied based on nursing non-therapy ancillaries, and as opposed to the routine component under RUG 4, which is over there on the right. Similarly with the rehab, you can see the variation from PT, OT, and speech, along with the rehab component under RUG 4. And again, we're talking specifically about urban rates here. So that's basically just where you can see where it's broken out, especially on the routine. They break out non-therapy ancillaries from nursing, and then each of the therapies is their own component under PDPM. So identification of a clinical category. What is the primary reason for that SNF stay? It may or may not be the reason why they were in the hospital. Okay? It may or may not be the primary reason why they were hospitalized. Okay, so having an understanding of why do they need SNF care, why do they need to be with you, is important to understand. So that's determined by your 5-day MDS. Okay, and that's determined largely by the ICD-10 code or codes that is put on the MDS in MDS section I-8000. Okay, so as an administrator, you want to have a system in place to where, you need to have a working knowledge of the process, but moreover, you need to have a system by which you have the ability to understand, making sure that your ICD-10 codes are all being listed. I-8000 is encompassing all of that, and that they are all mapping, because you don't want to miss out on a code that actually allows you to gain points for instance, in non-therapy ancillary. And we'll talk more about that here shortly. So if a surgical procedure done in the hospital, that may change the category, okay? Not necessarily that we just totally disregard what happened in the hospital, but we have to, I mean, it's just not necessarily the primary reason why they need to be with you. But if they had a surgical procedure, that could change the category. And so, you know, making sure that your MDS coordinator is got information within the patient record to be able to see what surgical procedures are indicated in Section J, because that could change the category that the patient is listed under. And so the clinical categories, you know, basically are reduced under PT/OT and clinical to 4. Okay, so major joint, non-orthopedic and acute neurological, other orthopedic, and medical management. And as you can see under other orthopedic, that may be some non-surgical orthopedic or musculoskeletal procedures or orthopedic surgery, spinal surgery. Under medical management, you have a lot of different things that can fall underneath that, such as acute infections, cancer, pulmonary conditions, cardiovascular issues, and then of course, general medical management. So you've got a lot of things that kind of roll up underneath these 4 clinical categories. So you start with the ICD-10 code. You identify what the default category is for that. So did you have a surgical procedure? Okay, so you know, did that qualify them for a different category? And if no, then they would go to the default category. If they did, then you have to identify whether it was non-orthopedic or major joint. Okay, so that's kind of your decision tree that your MDS coordinator is going to have to be able to follow. In addition to that, you come up with a function score. And so section GG of the MDS is where you capture their functional abilities and goals. Now, this is, of course, assessed during the first 3 days of admission. And what we're looking for is usual performance across 10 different ADL activities. Okay, so there's eating, oral hygiene, toilet hygiene, and then there's multiple categories underneath: average bed mobility, average transfer, and then average walking. So section GG and the ADL scoring is figured into all this. So you can see the score calculation is going to be dependent on the section GG where things are coded. Okay, and so remember that GG basically took section G and turned it upside down in terms of the coding. So you can see the section GG codes for their usual performance, whether it's independent all the way down to not attempted. And so their function score can range anywhere from 0 to 24. And these function scores apply to both the PT and OT components under the PDPM. Okay, so let's look at this in terms of case mix classification groups. So in major joint or other orthopedic, you can see the functional scores. Okay, so you've got 0 to 5, 6 to 9, 10 to 23, and then 24. Now, depending on which category they are classified in, you've got the case mix index that's applied for both PT and OT. Remember I said those functional scores apply to both of those components. And so their case mix index for each one of those components, depending on how they're classified, major joint or other orthopedic, are added together for a total case mix index. And then so you can see, depending on their functional score and case mix index that's applicable, what kind of rate impact that actually has. So your rate can actually go be positively, or in some cases where their score is 24, could actually be negatively impacted. In addition, medical management and non-ortho, same thing. You've got the functional score ranges combined with a case mix index applied to both PT and OT for a total. And then again, as you can see, the rate impact. So the higher functional score, those 24, basically means that their case mix negatively adjusted. Okay, so that piece has a negative impact on your overall rate. As I said earlier, we have an adjustment factor that is also applied for PT, OT, and we'll talk about non-therapy ancillaries here shortly. But so you can see there's an adjustment factor that basically goes about every 7 days after the first 20. Okay, so based on their days 1 through 20, it's a neutral adjustment factor. You get the whole rate. Okay, so and if you'll recall, days 1 through 20, Medicare pays what? 100%. Okay, so you get 100% of the rate on these two components as well. Starting with day 21, however, it goes down roughly 2% each successive 7-day period. Okay, so days 21 through 27, it's adjusted down 2%, all the way down. So by the time you get to the end of a benefit period, if they happen to go all the way to day 100, then at that point in time, if they're still receiving PT and OC services at day 100, then your adjustment factor on your rate is going to be 0.76. Okay, so it's adjusting down. Speech, as I said, PT and OT are split out, but they share a lot of commonalities in terms of the rate calculation. Speech, however, is an entirely different animal. And so speech is calculated based on the presence of 3 conditions. How they are, whether they have an acute neurological clinical classification, what kind of comorbidity they may have, which is driven by section I and O of the MDS. And then lastly, their level of cognitive impairment. And this is key, because if you've had any knowledge about the RUGS system, we know that cognitive impairment was kind of buried in some of the very low-level RUGs. They used to have 66 RUGs, and they were very low-level, low-paying categories that were paired basically with behavior. So this is really the first time that a payment system has truly recognized cognitive impairment as it relates to a skilling service. And so your BIM score that's associated with the MDS, so the BIM score is less than or equal to 12, will be an indicator of cognitive impairment. And so having at least moderate impairment will have an impact on your overall, will have an impact on the speech component as well as your overall rate. Okay, so the comorbidities. So as I said, section I and O of the MDS. And so what we're going to want to see is that, under section I, aphasia, and then ICD-10 codes associated with laryngeal cancer, so you can see aphasia, CVAs, hemiplegia, traumatic brain syndrome, and then some of the codes that go into it in that center column. And then section O also encompasses, trach care or ventilator or respirator. Okay, so all of these are comorbidities that impact the speech component. Additionally, whether they have the presence of a mechanically altered diet or swallowing disorder. And so both of these, of course, were found in Section K of the MDS. And so we want to look at not only their comorbidities, but whether they have presence of these conditions as well. Okay, so as I said, what we're looking at here is all of these case mix conditions. They're acute neuro, related comorbidities, or cognitive impairment. Okay, so whether they have none, 1, 2, or 3 of those conditions, and then you combine that with the presence of whether they have a mechanically altered diet and or a swallowing disorder. Okay, so let's, as an example, let's look at the rate calculation. So for example, a patient may have let's just say they have 2 of those conditions or comorbidities, which may or may not include cognitive impairment. And so they have 2 of those conditions, but they have neither of those other conditions in terms of mechanically altered diet or swallowing disorder. Okay, so in that case, then the case mix that would be applied there, so they've got 2 conditions, but their diet or swallowing disorder does not apply, so they have neither of those. So you have 2.04 is your case mix index. Okay, and so that would be $45 a day going towards the overall calculation of your overall rate. And so in this condition, in this table, you can see, you can kind of take, the first column and then answer the question related to the second column from a case mix perspective, and then you can see the dollar impact over on the right. And yours may be different based on whether you're urban, rural, and of course you've got a local adjustment as well based off of the national rates. Okay, so moving over to nursing. So in nursing, we've got basically the RUG 4 major categories are all still in play here under the nursing piece. And so extensive services, special care high, special care low, and then clinically complex, and then of course behavior, cognitive impairment, and reduced physical function. Okay, so you've got all of these categories were also applicable to RUGs 4. The only difference is they've kind of been rolled up into fewer categories underneath these major headings. So besides those categories, we've also got the functional score for nursing, not just therapy, but nursing. So section GG, again, based on functional abilities and goals there, again, same assessment period during the first 3 days of admission, and again, looking at usual performance. No difference in terms of the ADL scoring in terms of how they go about doing it. It's just, which category is it applying to. Now, and the difference is under PT and OT, you had a range anywhere from 0 to 24, whereas with nursing, it goes from 0 to 16. Okay, so you can see here, the nursing functional score is looking at eating, toilet hygiene, average transfer, and average bed mobility. And so based on the function score, you've got these nursing categories, and you can start there in the upper left, and that's extensive services. You've got special care high, special care low, clinically complex, which is the CDs, CBs, CAs, and then behaviors, and then the cognitive impairment and those low-level conditions. Okay, so you can see based on the where they fall into that particular category, plus their function score, and then multiplied times the appropriate case mix index. It's important to note that, determinant of the nursing rug is based on the rug hierarchy and not, case mix, index maximization. And the other thing is within the nursing component, that particular rate will be increased by 18% if you've got somebody who has HIV / AIDS. And the adjustment, B20 must be on the UB04 for the SNF claim in order to be able to let the MAC know that this individual has HIV. Okay, so we've gotten through PT, OT, speech, and then nursing. So the last one is non-therapy ancillaries. Now this is where providers can really make hay when it comes to improving their rate. If they are properly capturing all of the information in the MDS that needs to be captured based on how many points are assigned. So there's 50 different MDS items, many of which will be based on ICD-10 codes, of course, which are part of the MDS, and it includes diagnosis or extensive services, okay? So you got 50 different categories in where you may be able to earn points based on whether that it applies to that particular patient's condition or needs. And so what we've got here is you can see all of these different diagnostic or diagnoses or services that are required, and whether or not they are ICD-10 based, whether they come off the SNF claim, for example, on HIV/AIDS, which is the B20 that I said, and then or whether it's MDS. And so if it's a check mark, then that's going to be coming off of the MDS. And you can see the applicable number of points that are derived based on whether that patient, whether this applies to that patient. So if you've got an individual that's maybe post-admission transfusion, well, that'll be reflected within the MDS, and that will earn 2 points. And so you can earn up to 24 or 12 points on this. Okay. And so based on how many points and whether it's, if you get all the way up to that threshold of 12, then you can see the applicable case mix group. So NF all the way up to NA. And then over there on the right, you can see the case mix index that's applied. So if you've got somebody that is that's got a lot of stuff going on, has a lot of needs, and we're capturing that appropriately, accurately on the MDS or within the ICD-10 codes, then you can see the adjustment from a case mix. So 3.25, all the way down to 0.72. And so, as I said earlier, if you'll recall, there's an adjustment factor that comes into play here as well, not just PT and OT, but in non-therapy ancillaries. So there is an adjustment factor for the first 3 days of the stay of a 3.0. And then, of course, it goes back to a 1.0 after days 1 through 3. The logic on this is basically that in many cases, patients who have all these various non-therapy ancillary needs, there's going to be additional cost to the provider to get this together and get the necessary things to be able to deliver those services to meet that patient's needs during the first 3 days. Okay, and so the expectation is you're going to have higher level of cost associated with caring for that patient over the first 3 days. So they give you a case mix adjustment of 3.0. Okay, so all of those combine for an overall rate. Now, your rate is based exclusively on one assessment, okay? And that's your 5-day admission assessment. You're still required to do a discharge assessment, but it simply doesn't do, it has no impact on your overall rate. The only time that you may have a change in your PDPM rate is if you have a change that warrants at what we call an IPA, or an interim payment assessment. And IPA does not stand for a beer in this regard. I'm not an IPA drinker. I like lagers, but in this case, we're talking about an interim payment assessment. And so the only time your rate could potentially change is if you select to do an interim payment assessment. Okay, so your admission assessment is done during days 1 through 8. And as I said, it covers the entire stay unless an IPA needs to be completed. For an interim payment assessment to be done, the assessment reference date can be no later than 14 days after the change into the first tier classification. And what happens is it pays from that assessment reference date until discharge unless another IPA is completed. Now you may ask the question, oh, well, when do I know whether I need to do an IPA? CMS has basically left that up to you. What they are going to be looking for, what the surveyors will be looking for, is that you have a consistent policy that you have in place that dictates when an IPA is warranted, and that you are consistently applying it. You're not cherry picking based on whether this will get a better rate for this patient versus that patient. Okay, so this aligns nicely with a significant change. Remember in the MDS, we have various types of MDSs that we used to do under RUGs. A significant change may, whatever qualified as a significant change previously may be something that informs you as to whether or not you do an IPA. The key here, however, is it's got to be significantly different enough to where that patient's needs and services have changed enough to warrant an IPA, and that you're applying that criteria on a consistent basis regardless of patient. Okay, so there's also a 3-day interruption window. So if a patient goes out, if the patient's readmitted from having, if they're readmitted within 3 days, then instead of having to discharge and then start over, you just pick up where you left off as far as your assessment and your care goes. Now, if they're gone more than 3 days, then your MDS coordinator is going to have to basically restart their cycle. The same thing would apply if they come to you from another skilled nursing center. The MDS cycle would restart there as well. Okay, so basically the 3 days is the limit before you have to start the MDS cycle again beyond that. As far as OBRA assessments go, those that are required under OBRA, there's no changes to those. Again, admission, quarterly, annual, significant change. The only changes to assessments really apply to the Medicare requirements, and those were reduced all the way just to the admission and the discharge, maybe the IPA. And so use of the Medicare PPS MDS for case mix determination, states are going to ultimately have to move their Medicaid payment rate structures to be reflective of the changes to PDPM away from the RUGS system. And CMS originally took more of a hardline position on this, but they've backed off and have given a little bit more time to states to allow them to evolve their systems over to this. So as an administrator, it's important that you have a good, thorough working knowledge of the PDPM system. Not that you necessarily become an expert, but that you know enough to understand how rates are calculated, what things go into it, so that you can ask intelligent questions of your clinical team as you go along, and hopefully you're meeting with them on a regular basis. So don't be a bug on the windshield and get, didn't see things coming. So how do you prepare as an administrator or an organization to be successful in PDPM? And so when it comes to ICD-10 codes, you want to make sure that you've got accurate documentation of diagnosis and any procedures. And so you want to assess your current process, make sure that your staff are clearly understand and competent to be able to, complete the MDS and do the mapping and do the things that are necessary to assure that you're capturing everything. And make sure that you've evolved from just sticking ICD-10 codes into the MDS to strategically using them and making sure they're accurate and actually prioritized. You want to make sure that your primary diagnosis code is reflective of what that patient's needs and the services that you're delivering. So again, ICD-10 has taken on a greater role in the overall process for payment, away from just the compliance piece. Section GG coding. As I said earlier, ADL coding was not good, was not consistent, and was actually leaving a lot of money on the table for providers, because my experience has been that who's assessing the performance level of patients relative to MDS. Generally, it's going to be the CNAs, right? And so, my experience has been is that, we have over time drilled into our frontline staff's heads that, the old OBRA adage, which is we want to help that patient achieve their highest practical level of functioning possible. Okay, so we want the patient to, to be successful in their care goals. That leads us down a path that makes us see that patient in maybe better light than, they really are. And so on the other side of the coin, when it comes to Medicare, Medicare doesn't pay us for what the patient can do. Medicare pays us for what the patient can't do, or what we have to help them do when it comes to ADLs. Okay, and so we have to help our frontline staff understand the difference. And so take credit for what we, that patient can't do, or what we're helping them to do when it comes to ADLs, and reflecting that appropriately within our Section GG coding. And so we have to assess our process and make sure that our education is provided on the impact on PDPM to our staff. And then, as the slide says, start coding as if payment depended on it, because it does. Okay, so functional scoring is two-dimensional. And so you can see is, the category that's used is major joint, clinically complex, and no depression. And so you can see the impact of the functional score on the rate component across PT, OT, and of course nursing is in the red. Again, impact of functional scoring based on PT, OT, and nursing payment rates. Again, using a major joint resident who has a clinically complex nursing category with no depression. So you can see that the overall impact of functional scoring. Nursing has a good proportion of it. When you start getting into the higher level of scoring, you can see the breakout is more even. But over there in the functional score of 5, look at the dollar impact. A lot of that is impacting your the nursing piece. The nursing piece has a greater proportion of the overall impact. Okay, so therapy service model. Again, as I said, rehab is simply another ancillary service, no longer a payment driver. So you want to make sure that you've got appropriate therapy provision within this new model to achieve resident goals and outcomes. And so you want to make sure that you are identifying best practices, care paths for rehab. Many therapy companies have got these in place now, that you have open discussion with contract providers, and the role of restorative is greater than ever. I would argue that they should have played a larger role in RUGs and had the capacity to, but most providers really didn't give it a lot of credence. Restorative now is really a major partner in this overall provision of therapy. So therapy nursing communication, making sure that you truly have a team approach, an interdisciplinary team. Make sure that your communication system between those two areas is current and ongoing. Make sure your restorative program is robust and that you're meeting the education needs of your nursing staff. And whether or not you have formally appointed individuals in a restorative capacity, or whether all of your CNAs are doing restorative. I mean, those are two different schools of thought. One's not necessarily any better than the other. It's whatever works best for you. But making sure that restorative is incorporated as part of your overall program for delivering therapy services. Okay, so Medicare contractor reform. Before we move into this, any questions? I know we've kind of drilled down into some a larger number of or a little bit more detail on PDPM. And so I'm going to stop here. What kind of questions? Was I clear enough on my explanation of how the rate is computed? What additional information can I give you to help you better understand PDPM?
I have a question about a previous area you talked about.
Okay.
In category 2, you said SNF doesn't cover transport for dialysis patients. So then does the facility just eat the cost of that, or how does that work out?
No, SNF does not pay for it.
Right.
So that is something that the ambulance company would bill Part B for directly.
To the nursing home. Okay. All right. Thank you.
Mm-hmm. Other questions? Was the piece on PDPM helpful?
Yes.
Yes.
Okay.
Yes.
Very good. All right, so Medicare contractor reform. So, as I said earlier, you're primarily going to be interacting with your Medicare Administrative Contractor, your MAC. Okay. You typically don't deal with CMS directly when it comes to payment. CMS has contracted or subcontracted these functions out to various Medicare administrative contractors. And as I said, Novitas applies to us here in Oklahoma. And so, they used to be called fiscal intermediaries if you've been around any amount of time. And of course, you've got carriers under Part B. And again, we don't deal directly with CMS generally when it comes to payment. Novitas we are in jurisdiction H, and jurisdiction H encompasses all of these states. And I always, and if I'm stepping on someone's toes, I'm sorry, but Oklahoma always comes before Texas. So, as well as all these other states, but Oklahoma is always before Texas. So these are the states in jurisdiction H. Program resources, and of course, what the MAC is doing is that's where you're billing your claims to. And as I said, their role is to assess, making sure that the claim is a clean claim, meaning that it's accurate, it's complete, and it's got all the appropriate codes entered into it. However, as I said earlier, there may be some questions, and so the MAC may come back to you and request additional information to support a claim. And so they may have what they call an automated review, or they may have, oh yes, my OU is showing. They may have an automated review, and so you're really not going to know whether or not they've done a review of the claim or not, because they're doing it's an automated. A complex review is where they actually contact you and ask for additional documentation. And so the key with that is your response. You want to make sure that your response to that development request is complete and timely. Okay, so when they ask for additional information, you want to make sure that you're giving them the complete picture of what they're asking for. And so that may mean that if they ask for something for a specific claim, you need to go back in terms of your nursing notes and provide the whole picture, which may mean that you need to give them more than just maybe a specific date that they ask for. And so from that, they then have the ability to, they will make the payment. Recovery auditors we'll get into in just a minute. Okay. Program resources. So your fiscal intermediary, the MACs, as I said, Novitas Solutions is our Medicare administrative contractor. And so there's the link. A lot of good stuff on their website. There's also some CMS electronic resources. You've got their quarterly provider updates, MedLearn Matters. A lot of good stuff comes out in MedLearn Matters. I would highly suggest that you subscribe to that. And then Medicare and You, which is an electronic resource, but it is more of a consumer-driven or based audience for this publication. However, it's an excellent publication because even as a provider, it gives you a lot of good information, and it helps you understand what beneficiaries are seeing / hearing from CMS. It also has good information about deductibles and things of that nature. Again, it helps you kind of be more holistic in your understanding of the Medicare program because you're seeing it both from the provider as well as the beneficiary side. And so, as I said, our objective is to be the expert on the Medicare skilled nursing benefit in our communities. And so you want to be able to perpetuate that by having a thorough knowledge of it. Some implementation strategies. Communication. Up, down, sideways, and crosswise. I mean, your interdisciplinary communication process has got to be flawless. Case management. We've not really done a lot of case management in the past. That's usually been a domain that's been exclusive to the hospital setting. However, this type of system really requires that we become, better in terms of managing each patient throughout their stay. And so having some good skills in case management will go a long way. Understanding ancillary requirements. We talked a little bit earlier about those things, those categories that are excluded from the bundle, but also understanding, what is included and having those, systems in place to make sure that you're managing your ancillary expenses accordingly. You can get the best rate in the world under PDPM, but you could just as easily have equal or even greater cost if you don't manage your expenses accordingly. Same thing with staffing. Understanding that acuity is a driver of what kind of staffing you have. And so if you are in a Medicare environment, you may have patients who have a higher level of acuity. And so understanding what is the best way to deliver those services to that patient and get the outcomes that they need in the most cost-effective way. So I'm not suggesting that you skimp on staff. In fact, labor, those CNAs are the backbone of your success. But at the same time, I do see occasionally, well, more than occasionally, I see a lot of, especially on the not-for-profit side, I see a little bit more of a tendency to overstaff. And while that may be great from a customer satisfaction standpoint, that isn't necessarily a good thing when it comes to managing your expenses underneath your Medicare rate. So being strategic and having the right amount of staff for the right type of care for each patient. And then financial considerations, understanding the cost of care as opposed to, similarly to what I've already said, understanding that you can have the best rate in the world, but if you don't manage the cost of care underneath it, it's not going to get you where you need to go in terms of the margin that you're looking for. Some other changes, kind of looking into the crystal ball a little bit. There's ever since back around 2008, you've got some increased oversight. There was a shift in the emphasis from what they called fraud to what they call improper payment. And by that shift in what the way they're categorizing things or the way they refer to things is fraud requires a pretty high level of proof in order to validate, whereas improper payment gives a whole lot more variety or leash to CMS in which to oversee and in many cases either reduce or recoup payment based on medical necessity and other issues. When it comes to fraud, CMS estimates that about 10% of the costs in the program are fraudulently billed. An example here, a durable medical provider, 8 DMA suppliers accounted for almost 57 million in fraudulent claims. And so that's why you have Medicare contractor reviews and other contracted reviewers involved in checks and balances to assure that Medicare is paying the right kind of, the right rate to the right provider at the right time. And again, why the additional scrutiny? As I said, program integrity, they've moved from the fraud to improper payment. So you've got the MACs who are doing prepayment reviews. You've got recovery auditors who do both pre and post payment reviews. ZPICs, which have historically been directly attributable to allegations of fraud because they report directly to the Office of Inspector General. If you have a ZPIC visit, somebody is alleging fraud. And there is a prior to the pandemic, there was some traction that was being gained, and I haven't, I'm sure this has kind of taken a back seat, but moving all of these functions to consolidating them to what they call a UPIC, which is a universal programming integrity contractor. And so they would be looking at things across whether it was allegations of fraud or not. So those were on their way, and we'll see where that happens down the road. Problem areas, per CMS, improper payment problem areas, as again, services that are not able to be supported, so they are deemed to be medically unnecessary. Things that are coded incorrectly. Improper problem areas also failure to submit appropriate documentation requested. When I said you get a development request, one of those is being timely in your response. That's what this talks about. If you're not timely in your response, then it's an automatic recoupment. And so that's not something that most organizations can, survive on a routine basis. And then some Medicare secondary payer situations. So for example, Medicare expects to be the provider of last resort. And so if you've got a patient that you're providing care for that is a skilled service, but should have been paid by another payer source, maybe because it was a workers' comp situation, or maybe it was a car wreck. And so you've got another insurance company that should have been on the hook for payment instead of Medicare. So that's why that Medicare secondary payer piece as part of your admission process is so important. Okay, so keeping that in mind as far as assessing that on a regular basis. Most common reasons for claim denials: having or not having the physician's level of care, cert, and research in place or not dated, or research not completed, signed or dated by the physician. Initial plans of therapy plans of care not certified by the physician. And I mean, these are the 700 and 701 forms. And then nursing documentation not supporting condition of the beneficiary requiring skilled level of care. That is key. Your nursing documentation should be able to clearly reflect a difference in the care level being provided. And that's why it's so important to be looking at your documentation on a regular basis. So what can we do? MDS accuracy. It's all about systems. Starting with making sure your MDS is accurate, monitoring your performance. Again, this is part of that quality improvement that I talked about earlier. Tracking your performance, comparing against yourself and to the industry. Objectively looking at your documentation. As I said, if you can't go into patient records and clearly see a difference between that patient who was with you prior to being Medicare Part A versus, well, they were in a Medicare Part A stay, that documentation should show basically a different patient in terms of their care needs. And if that documentation doesn't support that, then it's suspect and is subject to possible additional scrutiny. And then having systems in place to regularly meet, review, monitor, and discuss what's going on with each one of your Medicare patients. This is either can be combined with or separate from a triple check process, which is something we recommend be in place before that claim is transmitted to the MAC. Lastly, Medicare revalidation. Your provider enrollment, your provider number had to have been at some point applied for and was approved by both the Medicare administrative contractor and the CMS regional office. And so what's in place now is that Medicare is saying we want every single Medicare provider, whether they're an institutional provider or whether they're an individual practitioner, we want them to revalidate their enrollment every 5 years. And a lot of the background of this is many providers enrolled prior to the electronic system being in place, which is called PAYCOS, Provider Enrollment Chain Ownership System. And so they want to update that information in PAYCOS. Also, this is, an opportunity for them to, kind of screen to make sure that there's no improper, that there's no fraudulent enrollments going on, people that have, fraudulently obtained a provider number and are billing in order to basically steal from the taxpayer. And so that's the background on revalidation. As I said, information is, for many providers, is outdated. There's been a lot of non-compliance. There is a requirement in place. Any change to your enrollment information in Medicare is expected to be reported within 90 days. There's a lot of non-compliance with that, and that's part of why they decided to do revalidation. And then, as I said, concerns related to fraud and abuse in the Medicare program. And so what is required is you are notified by the MAC of a need to revalidate your Medicare enrollment. You'll get a letter. Do not unilaterally say, hey, I'm going to go ahead and revalidate. If you take the initiative and try and revalidate your enrollment without being asked by the MAC, it'll just get kicked back. This is initiated by the MAC, so wait for that letter. Now, once that letter comes, you have to fully complete, either electronically or hard copy, a CMS Form 855, and for skilled nursing, that's a 855A, and then return the form indicated on the letter within 60 days is generally the time frame that they give you. And so once you return that to them, then be able to respond timely to any additional questions after you've sent that back to them. If you don't respond, then your billing privileges are suspended and you basically have to you start all over. And I will tell you that you have to, if you get your billing privileges terminated, you have to apply for a new provider number. And that for a new provider can take anywhere from 9 to 15 months in which to get that number approved again. So, and again, the revalidation is intended to cycle through all providers every 5 years. So if you haven't seen this for your particular building, you will. It will come at some point. Okay, so we're right at 11:45. What questions do we have? Don't everybody speak at once.